Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning in to my latest video. So the patient who attended with bilateral otitis externa, the patient's right ear is the worst of the two. This is the patient's left ear that we're just examining. So we're going to start off with the right ear, the worst of the two ears, and you can see we're right near the entrance here, and this dead skin and wax is presenting itself almost as like a golden colour. Now, dead skin, keratin, generally has this appearance. Wax is more, I would say, a browny colour, a light brown, dark orangey colour, and whereas dead keratin skin starts off more golden, more orange, and as it oxidizes, it can turn into a similar colour to earwax. Now, the patient actually lives abroad. They moved to Singapore, and they regularly come back to the UK. And they find as though since they've immigrated to Singapore, because of the heat and humidity, they've developed otitis externa, and they have to regularly have their ears cleaned in Singapore. They are fortunate to be able to treat by two UK-born, should I say, and trained ENT surgeons who have also moved to Singapore and set up their own clinic there. So they visit the ENT clinic, I think, every 3 or 4 months. And with this dead skin, so with this otitis externa, this skin, as it dies and sheds, it's just like psoriasis. The skin just builds up inside the ear, and the skin also gets infected. They generally get loads of fungal spores. As you watch this right ear procedure unfold, there is some residual dead skin keratin that's embedded onto the eardrum, and you'll see a few fungal spores there. So the patient is prescribed some earwax drops and also some cream to apply as well. Cream can always be a bit difficult to apply inside the ear, but the patient's been doing it for a while now, so they've become accustomed to do this safely. So I'm just using suction here. We're just trying to break up this dead skin plugs that's near the entrance. So although it has the appearance of earwax, it's actually not. It's more dead skin. And you can see the fresher layer of skin that's enveloped this plug of skin. And the core of the plug, which is what I've got a suction grip onto now, that's the oldest dead skin. So this skin originates from the surface of the ear canal, and then you get another layer of dead skin that appears at the surface, and this one then goes into the ear canal, and you get this constant ribbons of dead skin, really, that crawl over each other as they die and shed, with the oldest layer of dead skin at the core of the plug. So we can see we've removed the occlusion from the ear canal. In the distance there's that dead wax, dead skin, with fungal spores. You can see the white spores on there. Now, it was quite strongly adhered, this was. So I tried to get a suction grip onto it, but it wasn't. It was lodged in the anterior recess. So what I'm going to have to do is elevate this dead skin, as you can see I'm doing now on the anterior canal wall. I'm going to revert to, it's a bit of clarinetting. So clarinetting is when the skin violently flaps at the tip of the suction probe. So I've reverted to a fine end gauge. This is, I feel, a lot better at removing dead skin. You get far less clarinetting. Slowly but surely, you can see the fresh layer of healthy skin of the ear canal. All this is a dead coating. It was like a snake skin. It was really, really tough, this skin. Now, this skin, I've loosened it all the way off the anterior canal wall up to the eardrum, to the anterior recess. And I'm just trying to tug it off now, tear it off the eardrum so we can remove this plug. It was really difficult. I think I used some forceps at one stage as well. So this skin is an epithelial lining. So epithelial is the outermost layer of skin, and in the case of the ear canal, the bony part at least, so the inner 2/3, and the outermost layer of the eardrum membrane, which is made up of 3 membranes, we only have the epithelial lining. So this epithelial lining skin, it's 5 sub-layers of skin, and those individual layers collectively are known as stratified. The skin cells in shape are more round, and they are pancake shaped almost, and so you get different types of skin cells. You get squamous, which is kind of these flat pancake type of cells. which are laid onto each other and they sit side by side, or you get cuboidal skin cells, which are rectangular in shape. And the skin that directly lines the ear canal, that's the fresher layer of skin, and that receives all the blood flow. The blood vessels are nearby. So as that skin multiplies, duplicates itself as a process. So I'm just removing this plug off the eardrum. As this freshest most layer that's tightly adhered to the canal wall duplicates itself in a process called mitosis, we call that a sister cell that's created, and this sister cell pushes upwards the original parent cell. So this original skin that was lining the ear canal is no longer directly on the ear canal, it's been pushed up by its sister cell. Therefore, it gets further away from the blood vessels, and therefore the skin becomes a bit drier. And again, as that skin layer duplicates itself, we get another sister cell, which then pushes this skin layer even further away from the ear canal. So it's not receiving as much blood from the blood vessels because it's further away, until the outermost layer of skin that was originally on the surface of the ear canal is so far away from the blood vessels, it begins to die, it begins to shed because it's not receiving any blood flow. All the fluid within inside the cell, what we call intracellular fluid, where all the organelles of the cell live and all the chemical reactions occur within the cell, that fluid is no longer retained by the cell, so the skin really dries. And replacing this intracellular fluid is a protein called keratin. So keratin is the same protein you find on your fingernails and your hairs, and this keratin has a browny golden appearance, hence why skin is generally that colour. Keratin is actually quite good in the ear. It helps it's hydrophobic, so any water that enters the ear, it tries to repel that so it doesn't penetrate within the cell and cause an infection. And also keratin has the ability to attenuate UV harmful rays, so sunlight, any harmful rays from the sun. It has an ability to reflect off the keratin. Sorry, I'm pausing for a moment. I'm editing. I edit these videos on my phone. I just think it's a bit more convenient, easier for me to do, and I'm just having loads of messages appearing on the screen, so I'm having to flick these away so I can watch the video as I narrate. So you can see we're nearly done here. I'm just trying to remove as much dead skin as I can. It's just a bit at the entrance. We know we're near the entrance. We can see all the hair strands there. You can see this dryness as otitis externa, eczema, if you like, of the ear. And there's a residual piece of skin on the eardrum that, because the patient's so used to the procedure, very, very still, I just decided to remove that for her. So typically as the skin dies, you'll see it in the left ear actually, it's a good... within the ear canal, you can see the migration route of skin. So this skin starts dying and shedding from the eardrum. And as the skin dies and sheds, it moves sideways out of the ear like a conveyor belt. Think about a ripple. If you have a stone that you drop in the centre of a pond, you get this ripple effect. So imagine the eardrum almost being the ripple. So the skin that's on the eardrum, as it dies and sheds, it ripples outwards. And slowly but surely out of the ear canal. An average migration of dead skin from the eardrum to out of the ears around 10 months. And that's because the average rate of migration is about 3 millimetres a month. And if you average it, the length of a normal ear canals, you can just average it out to be 3 centimetres. And on the left side, you'll see the trail of keratin migrating from the eardrum out to the ear. So this is just partially occluding dry skin right at the entrance. Once I remove this, you'll see a layer of skin that's tightly adhered to the canal wall. Let's just get this out first and I'll show you it. And it's beginning to, you may have seen this at the bottom, it's like a trail. Okay, so you can see that the base of the ear canal, you will get a better view. There's like a path of dead skin that goes to the eardrum. Just dead skin, just peeling it off the canal wall. Well, that's the posterior lateral canal wall. So lateral means near the entrance, posterior is the back part. You can just see how golden it is. That's all the keratin, all the protein. Just waiting for you to get a better view. So can you see that on the right hand side? You can see there's a trail of skin, like a footpath that goes to the eardrum. So that's the natural migration route of the skin from the eardrum, and it's slowly trying to come out of the ear canal. Because of the psoriasis, the eczema, the otitis externa, this skin has remained there. So just to the right, we're going to be peeling it off now, so you'll see the underneath trail. It's quite distinctive. There we are. It's almost like a glitter effect. So that's a good image and video of the migration route, and you get loads of these. It's just not one path, you get multiple paths, and you don't normally see it. Only in some cases you can see it. So the skin, it's really tightly adhered. It is dead. It's not going to really move on its own accord. We know that the patient does suffer from otitis externa. They do get this natural buildup of skin in the ear. It's just causing them irritation, so we're trying to remove as much as possible. And this is that trail of skin. You can see I've just got onto it and just trying to bring it off. Some blistering there. That's quite normal when we remove skin because it's so tightly adhered to the canal wall. She's got quite a bendy ear canal actually. Yeah, it's quite a prominent anterior recess. So again, just come back to near the entrance. This is dead keratin. I'm just using a fine end gauge just to gently elevate off the canal wall. When patients do have otitis externa and they get itchy ears, they really enjoy the procedure because there's parts of the ear that they always, it's easier said than done, but you don't want to be itching your ears if you've got an itchy ear because you're just going to make it worse in the long term. You're going to be scratching the skin, maybe cutting into the deeper part of the ear canal, exposing it to the elements, so you're more prone to an infection. As you scrape the skin yourself, if you put too much pressure, you can obviously abrade your ear canal. As that the healing process itself can be itchy, so you're going to be itching your ear again. When we're removing it, we're just removing the outermost layer of dead skin. And patients enjoy it because there's parts of the ear that if they do itch, they can't reach themselves. And just see how dry that is. So they are going to be, when they return home, they're going to be putting their various drops and ointments that they've been prescribed by the ENT doctors who the patient normally sees in Singapore. So again, we're on the lateral anterior canal wall. So lateral again near the entrance, on the anterior, so these are the front parts. There's some more crusty dead skin here, so it's a bit more tightly adhered. Now, because we're on the cartilaginous portion, the outer third, we can just put a bit more pressure to loosen this. We wouldn't be able to do this on the bony part. It would be very uncomfortable for the patient if we did. So the skin that lines the outer the outer third of the ear canal is a lot thicker. It's about 1 millimeter in thickness, whereas the skin that lines the inner 2/3 and the outermost layer of the eardrum is almost 10 to 15 times thinner, so at least 0.1 millimeters in thickness, if not thinner. These patients are already aware. They'll be giving very strict water precautions by their ENT doctors in Singapore. So when you've got, and I advise everyone to avoid water, but more so if you suffer from otitis externa because it's just going to exacerbate the condition. Patient was really, really happy. Obviously, they do see ENT, so very high standards that I had to adhere to. I sent the patient to video who's they've never seen the procedure being performed, and they're very complimentary about my work and how delicate I was, and so that's always good to hear. In fact, when they next visit the ENT doctors in Singapore, they're going to be asking them to get in contact with myself with this technology. I hope you enjoyed that video, guys. Take care. I'll speak to you soon.